Good morning, everyone. Today we will discuss clinical cytogenetics and chromosomal abnormalities. Chromosome disorders represent a major category of genetic disease. They affect approximately 1 in 160 live births and are responsible for a significant proportion of reproductive wastage, congenital malformations, mental retardation, and cancer pathogenesis. Understanding these disorders is essential for any clinician or genetic counselor. Let us begin by defining clinical cytogenetics. Clinical cytogenetics is the study of chromosomes, their structure, and their inheritance as applied to the practice of medical genetics. This field bridges basic chromosome biology with patient care. Cytogenetic analysis allows us to diagnose genetic syndromes, guide reproductive decisions, and predict disease progression. Techniques range from conventional karyotyping to advanced molecular methods. The ultimate goal is to correlate chromosomal findings with clinical phenotypes. Chromosome disorders form a major category of genetic disease. They are responsible for reproductive wastage, meaning miscarriages, congenital malformations, mental retardation, and the pathogenesis of cancer. Specific chromosomal abnormalities are responsible for hundreds of syndromes. Remarkably, chromosome disorders are more common than single gene disorders. This highlights the importance of cytogenetic analysis in routine medical practice, especially in pediatrics, obstetrics, and oncology. The prevalence of cytogenetic disorders is substantial. Approximately 1% of all live births have a significant chromosomal abnormality. Among pregnancies in women older than 35 years, about 2% show abnormalities. Most strikingly, half of all spontaneous first trimester abortions have a chromosomal abnormality. These figures underscore the critical role of chromosomes in early development and the high frequency of errors in human reproduction. When should a clinician order a karyotype? First, in problems of early growth and development, failure to thrive, developmental delay, dysmorphic facial features, multiple malformations, short stature, ambiguous genitalia, and mental retardation. Second, in stillbirth and neonatal death, cytogenetic analysis of fetal tissue can explain the cause and guide future pregnancies. These indications are standard in clinical genetics and pediatrics. Additional indications include fertility problems, couples with infertility or multiple pregnancy losses, and women with primary or secondary amenorrhea. Family history is another indication. If a first-degree relative has a known or suspected chromosomal abnormality. Neoplasia, Many cancers acquire specific chromosomal changes that guide diagnosis and treatment. Finally, pregnancy in a woman of advanced maternal age, typically over 35 years, is a standard indication for prenatal karyotyping. A uniform system of chromosome classification is internationally accepted. Chromosomes are identified by size, centromere position, and bending patterns. The pattern of bands on each chromosome arm is numbered. Using this numbering system, the location of any band, DNA sequence, or gene can be precisely described. This standardization allows cytogeneticists worldwide to communicate findings clearly. For example, 46-XY del 4 P116.3 precisely describes a deletion on chromosome 4. Chromosome analysis requires living cells that can divide. Common cell sources include fibroblasts from skin biopsies, lymphoblastoid cell lines from blood, bone marrow for hematologic disorders, and fetal cells from amniocentesis or CVS. Banding techniques include G banding, Q banding, and R banding. Special procedures include C banding for centromeres, high resolution banding for fine detail, and fragile site detection. Molecular cytogenetics includes FISH, SQUI, and CGH, methods we will discuss later. Chromosome banding is essential for identifying each chromosome and detecting structural abnormalities. G banding, or Giemsa banding, produces alternating light and dark bands. Light bands are gene-rich and early replicating. Dark bands are gene-poor and late replicating. Q banding uses quinacrine and fluorescence. It is similar to G banding. R banding, or reverse banding, is the opposite pattern and is useful for studying telomeres. Banding resolution typically ranges from 400 to 850 bands per haploid set. Higher resolution allows detection of smaller abnormalities. Chromosome abnormalities are divided into two major categories: numerical and structural. Numerical abnormalities involve changes in the number of chromosomes, either too many or too few. Structural abnormalities involve breakage and rearrangement of chromosome segments, such as deletions, duplications, inversions, insertions, rings, and translocations. Both types can be present in all cells, which is called non-mosaic, or in a fraction of cells called mosaic, which often correlates with milder phenotypes. Polyploidy means the presence of one or more extra complete sets of chromosomes. Triploidy, which is 3N, can be 69th on XXX, 69th XXY, or 69th on XYY. It is seen in fetuses and is lethal early in life. It occurs in 1 to 3% of recognized conceptions. The usual cause is dyspermy, which is fertilization by two sperm or failure of meiotic divisions producing a diploid gamete. Tetraploidy, which is 4N, such as 92-fold XXXXX or 92-fold XXYY, is much rarer than triploidy. It typically results from failure of an early cleavage division. Both polyploidies are incompatible with live birth. The phenotype of triploidy depends on the source of the extra chromosome set. Paternal triploidy, where the extra set comes from the father, is associated with abnormal placenta, specifically partial hydatidiform moles. These pregnancies may continue longer but have severe placental abnormalities. Maternal triploidy, where the extra set comes from the mother, is spontaneously aborted earlier in pregnancy, usually in the first trimester. This parent of origin effect reflects genomic imprinting. Genes expressed differently depending on whether they came from mother or father. Aneuploidy refers to cells that do not contain a multiple of 23 chromosomes. There are missing or extra individual chromosomes. This is the most common and clinically significant chromosome disorder, present in at least 5% of all clinically recognized pregnancies. The two main types are trisomy, meaning 3 copies of a chromosome, and monosomy, meaning 1 copy of a chromosome. Both can have severe phenotypic consequences. Most aneuploidies are lethal, but some are compatible with live birth, as we will see. The most common trisomy in live births is trisomy 21, also known as Down syndrome, with karyotype 47XX plus 21 or 47 tone XY plus 21, seen in 95% of Down syndrome cases. Other trisomies observed in live births include trisomy 13, which is Patau syndrome, and trisomy 18, which is Edwards syndrome. It is notable that chromosomes 13, 18, and 21 have relatively low numbers of genes compared to larger chromosomes, which may explain why trisomies for these chromosomes are viable, while trisomies for chromosome 1 or 2 are not. Monosomy for an entire autosome is almost always lethal early in development. The only important exception is monosomy X, Turner syndrome, with karyotype 45X. Why is monosomy X viable? Because X chromosomes undergo X inactivation in females. Having only one X is tolerated, though it causes a recognizable syndrome. Monosomy for any autosome, for example, monosomy 21, has never been reported in a live birth. This tells us that human development requires two copies of most autosomal genes. Aneuploidy is generally caused by chromosome non-disjunction, failure of homologous chromosomes in meiosis I, or sister chromatids in meiosis II to separate properly. This produces a gamete with an extra chromosome and another missing that chromosome. Fertilization with a normal gamete yields trisomy or monosomy. Another mechanism is premature separation of sister chromatids in meiosis I instead of meiosis II. Non-disjunction frequency increases with maternal age, especially for chromosome 21. Structural abnormalities result from chromosome breakage and reconstitution in an abnormal combination. They are less common than aneuploidy, present in about 1 in 375 newborns. Here are some notation examples. Deletion 46XY del 4P16.3. Inversion 46XY in V11, P11P15. Duplication 46XX, duplicate 1, Q22, Q25. Insertion 46XX ins 2, 13Q11, Q31. Ring 46XY R7.2, Q36. Marker 47X6, Lomar. Translocation 46X6, T26, Q35, Q21, 3. Precise notation is critical for clinical reporting. Chromosomal rearrangements can occur spontaneously at low frequency. They may also be induced by clastogens, agents that break chromosomes, including some viral infections and many chemicals. Like numerical abnormalities, structural abnormalities may be present in all cells, which is called constitutional, or in mosaic form, meaning only a fraction of cells. The distinction between balanced rearrangements which have no net gain or loss of material, and unbalanced rearrangements, which involve a gain or loss, is critical because balanced rearrangements often have no clinical effect in the carrier. Structural abnormalities are classified by the pattern of breakage. First, two breaks on a single chromosome can produce deletions, inversions, duplications, or ring chromosomes. Second, translocation between two chromosomes involves single breaks on each chromosome, followed by reciprocal exchange. Third, Robertsonian translocation involves fusion of the long arms of two acrocentric chromosomes at the centromeres with loss of both short arms. We will discuss Robertsonian translocations in more detail. A Robertsonian translocation involves fusion of the long arms of two acrocentric chromosomes, chromosomes 13, 14, 15, 21, or 22, at the centromeres with loss of both short arms. Carriers have only 45 chromosomes but are phenotypically normal because the short arms contain only ribosomal DNA repeats, which are redundant. However, carriers are at risk for having children with unbalanced translocations. For example, a carrier of ROB1421 can have a child with trisomy 21. This is the most common clinically significant translocation.
The most common type of clinically significant chromosome is aneuploidy, always associated with physical or mental maldevelopment or both. Reciprocal translocations are also relatively common, but usually have no phenotypic effect.
The phenotypic consequences of a chromosome abnormality depend on four factors. First, its specific nature, deletion versus translocation versus trisomy. Second, the resulting imbalance of involved genome parts, how many genes are gained or lost. Third, specific genes involved. Some genes are dosage sensitive. Fourth, the likelihood of its transmission, whether the abnormality is inherited or de novo. These factors guide genetic counseling. Always remember, unbalanced karyotypes almost always cause abnormal phenotypes. For genetic counseling of unbalanced karyotypes in live births, several guidelines apply. Monosomies are more deleterious than trisomies. Missing a gene is often worse than having an extra copy. Complete monosomies are generally not viable except for monosomy X. Complete trisomies are viable only for chromosomes 13, 18, 21X, and Y. For inversions, pericentric inversions carry an increased risk of birth defects in offspring, and this risk increases with inversion size. Paracentric inversions carry a very low risk of abnormal phenotype because no unbalanced gametes are produced. The major numerical disorders are three autosomal trisomies, chromosomes 13, 18, and 21, and four sex chromosome aneuploidies, Turner syndrome, usually 45 the mix, Klinefelter syndrome, 47XXY, 47XYY, and 47XXX. Triploidies and tetraploidies account for a small percentage, particularly in spontaneous abortions. In live births, overall incidence is about 1 in 160 births, or 0.7%. Most autosomal abnormalities are diagnosed at birth, but most sex chromosome abnormalities, except Turner syndrome, are not recognized clinically until puberty. Balanced rearrangements are rarely identified clinically unless a carrier gives birth to a child with an unbalanced chromosome complement and family studies are initiated. The carrier parent is phenotypically normal, so there is no reason to test until an affected child is born. Unbalanced rearrangements are likely to come to clinical attention because of abnormal appearance and delayed physical and mental development. This is why karyotyping is indicated in any child with multiple congenital anomalies or developmental delay. To conclude our overview, we will examine three classic chromosomal syndromes in detail in future sessions. Down syndrome, which is trisomy 21, the most common autosomal aneuploidy, trisomy 13, also known as Patau syndrome, characterized by severe malformations, including cleft lip and palate and polydactyly, and Turner syndrome with karyotype 45.X, the only viable monosomy characterized by short stature, webbed neck, and ovarian failure. Each demonstrates key principles of clinical cytogenetics, genotype phenotype correlation, the importance of gene dosage, and the role of non disjunction.